is the neurologist's viewpoint on diabetes. Dr. Awadh Kishor Pandit, again from All India Institute of Medical Sciences, New Delhi, who's going to be talking about it. And as we speak, I would just like to draw everybody's attention to the YouTube numbers, which are soaring higher because of the content, and there are again a lot of questions which can be taken up after the talk. Dr. Awadh, you can share the screen, please.
Good morning, everyone, and I thank you, especially Dr. Namrata and all the Ophthalmological Society. And thanks, Dr. Lalit sir. And I would more rather focusing on diabetes. I have a very specific presentation which really overlaps with ophthalmology, and we really get good help from our ophthalmology colleagues. So, am I audible?
Yes. Please continue.
And so, just I'll start my presentation, and my presentation is it always diabetes or it is something else? So I will start my presentation. So this part I would not want to go in detail about the macula and optic nerve head, but as I think all the audience, they are very clear about all these points of having fovea, macula and optic nerve and the blood vessels. Now, we know what is the internal carotid artery, which starts after bifurcation of common carotid artery. And this is the internal carotid artery, which supplies towards our eye through the ophthalmic artery. And once this ophthalmic artery, then it supplies through the various branches into the optic nerve and into the retina and the other parts of the eye. And ischemic optic neuropathies are those patients who are more than 50 years and there are posterior ciliary arteries. They suffer through atherosclerosis, vasculitis, and hypoperfusion. And AION, that is anterior ischemic optic neuropathy, they have disc swellings more common than the posterior ischemic optic neuropathy. And these atherosclerotic ischemic optic neuropathies, they are more because they are known as non-arteritic ischemic optic neuropathies. Ischemic optic neuropathies, arteritic means we are dealing with some form of vasculitis. And non-arteritic is mostly the atherosclerotic risk factors, those who suffer ischemic optic neuropathies. So mostly the vasculitic part, the commonest we see across is the polymyalgia rheumatica associate or giant cell arteritis. They are mostly elderly, raised ESR, and non-arteritis, they are middle-aged to elderly, and they present with vision loss, and ESR and CRP are mostly normal. And arteritic, the degree of vision loss is usually very severe, and non-arteritic is less severe, but they have significant visual loss. Atherosclerotic risk factors are present here, and in arteritic, the improvement is rare, but in non-arteritic, 30% would improve. And these are the findings which I think ophthalmologists better explain. On arteritic papilledema, there will be cotton wool spots, disc hemorrhages, and the cotton wool spots. And FFA, we can see segmental choroidal hypoperfusion. And in non-arteritic, there can be disc edema, hemorrhages, and in FFA, it can be normal or there can be delayed disc filling. So I will start with a case. I would rather want my ophthalmology colleagues and audience to have an eye, because is it always atherosclerosis, or we blame diabetes or other metabolic diseases towards which causes this changes or the vision loss. So I would rather present a case and then go into discussion. So this is a case I'm presenting as a unilateral papilledema in a middle-aged patient. So she is a 45-year female. She presented to us with blurring of vision in her right eye, one eye, which was of 2 weeks of duration. So presenting problems, if we go in detail, there was blurring of vision in right eye, which was acute in onset, progressive in nature over the period of 2 weeks. And there was associated history of increase in headache because she had a history of headaches in the past, which was also increased in past 20 days. And history of generalized weakness was there for about 8 months. And there was no associated pain on extraocular movements. Otherwise, there was no history of transient vision loss. There was no history of scalp tenderness, myalgia, jaw claudication, or antecedent fever, neck rigidity, double vision, or any similar episode in past. And there was no ocular edema or surgery. There was past history of headaches, probably like migrainous, and the patient was on beta blockers and analgesics. There was macroadenoma in non-functional, and she had a history of hypothyroidism and not a known case of hypertension. So if we see the ocular examination on the right eye, which was symptomatic, she had vision of 6/18, and left eye was more or less normal, and there was no RAPD. Another eye examination was normal. And if we see the fundus picture on the right side, there was a disc edema and there was obliteration of the cup. And on the left side, it was more or less insignificant and it was normal. So considering young to middle age, there was 2 weeks progressive history of vision loss. And with this fundus findings and visual acuity, if we see visual acuity was 6/18 on the right eye. So first possibility we kept was ischemic optic neuropathy, non-arthritic, optic neuritis, compressive optic neuropathy, or could be idiopathic intracranial hypertension. And this was I think my ophthalmology colleagues would better understand this, but what have been explained to us is on the right side, if we see, there was a leakage in the disc in the superior quadrant. And at the end, there was significant leakage in the superior quadrant. So, and on the left side, it was normal. And also on OCT, there was superior quadrant of the right eye. It showed a increased retinal nerve fiber layer thickness. And on the left side, it was insignificant. It was normal. And if we see visual field, it was not much conclusive, except for on the right side, there was superior quadrant, but it did not show very significant on this visual fields examination. So patient was evaluated with considering those differentials which I told: ischemic optic neuropathy, IIH, idiopathic intracranial hypertension, and optic neuritis or compressive. So patient showed little less hemoglobin, but there was impaired blood sugar in the form of HbA1c of 6.3 and fasting of 124, and we consider fasting more than 126 as diabetes. And postprandial was also raised. So we kept a possibility of right eye non-arthritic anterior ischemic optic neuropathy because not a very elderly age, 41 years, there was impaired HbA1c, unilateral, acute onset, progressive diminution of vision, painless. Points which led us to think was the degree of vision loss, FFA findings, and the visual findings. But what was disturbing was there was no other significant atherosclerotic risk factors. So AION was little difficult to convince. So the patient was referred to us and we did a detailed neurological examination. But on general physical examination, patient was little overweight, otherwise no significant findings. And systemic examination also did not show any findings. So considering those differentials, patient undergoes an MRI and MRI brain, this is T2 axial sequence and FLAIR axial sequence. And this is the coronal sequence of the optic nerve and the chiasma. And this was MR venogram, which was also normal. So patient had the normal parenchymal imaging of the brain. And since we considered ischemic optic neuropathy, so patient also underwent an angiogram in which if we see the origin of the internal carotid artery, bilateral, it is normal. There is no stenosis. And intracranial also, there is no stenotic or severe atherosclerosis disease. So patient was further evaluated and patient underwent a CSF examination also. And CSF showed a raised pressure, otherwise of 28 centimeter of water, rest was normal. So here we get confused when we get this impaired glycemia, which is HbA1c 6.3, little middle-aged patient, and patient presents with this sectoral visual field defects, degree of vision, which is 6/18. So we kept possibility for AION, but also because of the raised pressure, there was a situation of thinking of it as a idiopathic intracranial hypertension with unilateral papilledema. So patient was treated with both the measures, mainly the raised pressure were managed using acetazolamide and topiramate, but also was given antiplatelets and statins. And this is the follow-up where we see the best corrected visual acuity got improved from 6/18 to 6/6. And also we see the comparative pictures on the follow-up. We don't see much changes, little disc pallor, which is appreciated at 2 months. Otherwise, this was the finding. So what confuses us is this atherosclerosis. And my point of concern here is this is a case of idiopathic intracranial hypertension, which presents with the ischemic optic neuropathy, and this atherosclerosis, sometimes it can be a silent bystander. That's all. Thank you.